Regarding reconstruction technique, there are muscle attached medially, that is sartorius, gracilis, and semitendinosus, anterior to posterior. Gracilis is rounder, semitendinosus is flat. I will do a 3 to 4 centimeter vertical incision, 3 finger breadths below the medial joint line, dissect the subsartorial fascia. I can do a hydrodissection, defy the fascia just above the gracilis, blunt instrumentation to isolate from MCL, isolate gracilis and semitendinosus, and harvest with tendon stripper. I can use open or closed tendon strippers. Keep knee flexed while harvesting to protect saphenous nerve. Muscle tissue are always inferior. Cut graft and prepare with number 2 Ethibond with a whip stitch on each side. Need a minimum of 20 centimeter length, 10 centimeter when folded. Place graft in saline moist swab to avoid desiccation. Now I will make a tight high anterolateral portal and tight low anteromedial portal. Debride ACL stump and do a notchplasty with a shaver or radiofrequency ablator. Femoral tunnel is the important part. Femoral tunnel isometric point at ACL footprint. Resident ridge to be identified and go posterior to it. Need to avoid posterior wall blowout as posterior as possible, enough to avoid graft blowout. It should be 9 to 10 o'clock in right side, 2 to 3 o'clock in left knee. To create more horizontal graft, knee is highly flexed and a beef pin is placed through the medial portal. Place guide wire, drill tunnel with drill, measure femoral tunnel, drill femoral tunnel, leave 5 to 10 mm for the button to flip. Place a line on the graph 6 mm to the femoral tunnel length to indicate point at which the graft is seated deep enough to flip the endo button. Now I will concentrate towards the tibial tunnel placement, just lateral to the medial tibial spine, 10 mm anterior to PCL in posterior half of ACL footprint, along posterior edge of anterior horn of lateral meniscus. 2 anterior will cause notch impingement, 2 posterior will cause PCL impingement. The tibial tunnel is drilled through the initial graft harvest incision. Tibial tunnel guide is placed through anteromedial portal while the scope is viewed anterolateral. Tunnel angle is 45 degrees. Dilate and do an intrafix tibial fastener. After tightening, ACL the knee, cycle the knee to achieve proper tension. Regarding pediatric ACL, physial sparing on transepiphyseal tunneling. Factor found to increase the physial injury: number 1, oblique tunnel position; number 2, interference screw fixation; number 3, high speed tunnel reaming; number 4, increased tunnel diameter more than 8 mm. I can do extraarticular McIntosh technique, iliotibial band tenodesis. ACL rehab is early post-op full weight bearing. Avoid open chain quadricep exercises. Cycling start at 6 weeks. Running start at 3 months. Twisting at 6 months. Contact sports at 9 months.